Hello, and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for June 21st, 2023. Thank you for joining us this month. Our presenter today is Dwight W. Burney III. Dr. Burney is retired after 34 years in practice as an orthopedic surgeon in Albuquerque, New Mexico. He has served in multiple roles for the American Academy of Orthopedic Surgeons, with his main areas of interest in surgeon-patient communication and patient safety. He has also served on the steering committee for Movement is Life. Movement is Life is a multidisciplinary coalition seeking to eliminate racial, ethnic, and gender disparities in muscle and joint health by promoting physical mobility to improve quality of life among women who are African American, Hispanic, Latina, or live in rural communities. The title of today's presentation is The Movement is Life Value Project. Welcome, Dr. Burney.
Thank you, Katie. Can you hear me now? I'd like to thank the Osteoarthritis Action Alliance for the opportunity to present this work. May I see the next slide, please? Since 2010, Movement is Life, which is now a 501c3 nonprofit organization, has been focused on the elimination of musculoskeletal health disparities. Limited mobility due to joint pain and osteoarthritis has a dramatic impact on comorbid health conditions, including obesity, type 2 diabetes, and heart disease. We know that African Americans, Hispanics, and women of all races suffer disproportionately from these conditions, and their situation is aggravated by the fact that they often receive disparate health care. The health care costs of managing these conditions are staggering. May I see the next slide, please? Our goal is to be a catalyst for change. Movement is Life mobilizes multidisciplinary work groups to develop measurable, short-term action plans that move the needle on critical factors that drive musculoskeletal disparities. May I see the next slide? In short, Movement is Life is really about behavior change. Use awareness of the problem to educate ourselves, and then for that to motivate our behavior to change in a positive way. We have the next slide. The vicious cycle of knee pain, limited mobility, and inactivity leads to obesity and comorbidity. Look on the white core of this diagram. You can see that the vicious cycle starts with joint pain, which leads to limited mobility, lack of physical activity, obesity, and increased pressure on the joints, which then creates the vicious cycle. And the obesity leads to the comorbid conditions. We also know that joint pain and osteoarthritis can be affected by social determinants of health, which are the light green layer around the core. These include your zip code, structural racism, and inequitable care, among other things. Then also, healthcare policy has large impacts on disparate care. And the pandemic over the last 3 years has really raised everyone's awareness in the public about these disparities. If I can see the next slide, please. Currently, healthcare in the United States is costly and complex. It's so costly that it's not sustainable. The incentives among payers, patients, and providers are not aligned. All of the stakeholders have different views of what's important. We know that fee-for-service still is a majority of the payment schedule, payment methodology for almost all care. So may I have the next slide? Fee-for-service has real problems. It just isn't. It has an emphasis on volume rather than value or quality. It devalues healthcare promotion or preventive healthcare. It really does not pay for education or follow-up. It's highly variable by provider and geographic location, And it also leads to overutilization and inappropriate utilization. If I could have the next slide, please. This is a model that shows that this slide shows different models on the spectrum from left to right along the arrow. Fee-for-service is on the left, where providers really have minimal financial risk or accountability. And as we go toward the right, we see increasing financial risk and increasing accountability for outcomes and quality measures. So what we're talking about are the models in the middle between capitation and fee-for-service. So if I can see the next slide. From the policy perspective, from the people who make healthcare policy, payment systems should decrease cost, improve quality, and fund all the needed services. So could I have the next slide? So who are the stakeholders and who gets to define value in healthcare? Next slide. This study from the University of Utah found a significant disconnect between what patients feel is most valuable and what policy incentivizes. Cost is the only factor in the value equation that all of the stakeholders can agree upon. Next slide. Alternate payment methods have significant unintended consequences. The data infrastructure that's required is very expensive. Algorithms can incorporate biases, and we know that some of the care algorithms have actually incorporated racist biases. The reimbursements are really not driven by outcomes, and it's very easy to game the system to shift risk and cost. May I have the next slide, please? For joint replacement surgery, these models incorporated quality measures, and one was the arbitrary hard stop for patients with a BMI of 40 or greater that would prevent them from being able to have joint replacement. And then the Affordable Care Act had the hospital readmissions reduction program, which penalized providers if the patient required an unscheduled readmission. These are carrots and sticks. These are incentives and disincentives to surgical care, and these really affect disproportionately people who are already victims of healthcare disparities. So this slide shows what has ironically come to be called cherry picking, which is recommended surgery for only optimal candidates, and lemon dropping, avoiding surgery for patients with comorbidities. Next slide, please. In 2019, Movement is Life published this primer on healthcare payment methods and how the definition of value varies among patients, providers, and policymakers. Can I have the next slide? Although an in-depth discussion of Operation Change is beyond the scope of today's presentation, one feature of Operation Change is focus groups with the participants in the different projects, and these focus groups yield very pertinent information on the disconnect that was noted in the Utah study. Next slide, please. The focus groups were made up of African American women in Cleveland, Latino women in Chicago, and community health care workers who were working with poor white women from rural communities in Kentucky. The next slide. The Operation Change focus groups identified several aspects of their health care that were valuable to them and several that were not. Have the next slide. These are examples of the frustrations that were identified by the members of the focus groups. More specifically, inadequate communication, and also who among us has not experienced this, where the doctor is so absorbed in the computer slide that they don't even make or the computer screen that don't even make eye contact with you. So could I have the next one, please? A lot of care that people received seemed incompetent and lacked attention to the patient's needs. This is a particularly poignant example of a provider wanting the patient to ignore a breast lump. You should be more concerned about your grocery bill than you are about this lump. Could I have the next slide, please? Bias and lack of professionalism. The doctor said, "Have you ever been addicted to any pain medication?" He just automatically wrote me off as a drug addict. And then a Latina woman in the Chicago group in the emergency room who lost her son to firearm violence. My son was covered in blood. His head was open. I heard the nurse when she said, "A gang member more, a gang member less." Could I have the next slide, please? The cost of care and challenges in encountering the system were very common complaints. Now they give you quotes up front. They ask you for that money in advance. Yep, that's the one thing you can count on, is getting the bill. No, we can't see you. Go to urgent care. Next slide, please. Common conditions are not recognized or managed appropriately. Many people recognize depression as this problem, and inappropriate advice from a primary care doctor about a patient undergoing surgery and chemotherapy, telling her that she is tired and can barely go to work, and the doctor is recommending that she go work out. Next one, please. Patients in the focus groups placed high value on effective, efficient communication, returning phone calls, having a good dialogue with the doctor. Next slide. Respectful, non-judgmental care. Okay. If I'm going to the doctor and you're my kid's age, you don't call me by my first name. Don't call me sweetie. Just to be considered as human beings. How are you feeling? Why are you here today? Next slide. Prompt, professional, courteous care. Who of us has not experienced this? The long wait, the sign-in time, and redoing the paperwork over and over and over again. Next slide. Personalized care. Interested in what I need. He didn't need me walking out of his office forgetting to ask a question. How long has it been since you've had an eye exam? I want to partner with my health doctor who will work with me compassionately. Next slide, please. Sensitivity to out-of-pocket cost. Is there a generic I can call in instead of the brand name brand? Okay, next slide. So what patients value is effective communication, an effective provider-patient relationship, timely care, cost-conscious care, unbiased, respectful, and comprehensive care, and professionalism. Next slide, please. Improving healthcare quality and reducing healthcare costs are laudable goals, and we should continue working to achieve them. However, policies that only focus on cost and quality measures miss the larger picture of what patients want and need from the healthcare system. These policies are ineffective and may even be more costly. We conclude that it's time to incorporate the patient's values into the value equation. The value monograph and related materials from the Value Project are available at the Movement is Life website, and Katie will be sending these out to you later. May I have the next slide, please? Thank you, Katie. To end this presentation, I'd like to encourage you all to consider attending the Movement is Life Summit in Washington, D.C. on November 30th and December 1st. I've been attending this summit for 10 years, and it has been a tremendous educational experience for me, and I'd encourage you to join us there. Last slide, please. So this is me. What questions do you have for me today? Thanks for your kind attention.
Thank you, Dr. Burney. And so we'll just invite anyone who has a question for Dr. Burney to type it into the chat, and I will read it aloud for him. One question that I had for you to get things started, Dr. Burney, is related to artificial intelligence. So, we've seen a lot in the news about that recently, and I'd be curious to hear your perspective on ways that artificial intelligence can be used to increase value for patients, or maybe there's a downside to it if it could devalue care for patients.
Well, I think we've all been hearing a lot about the upside and the downside of artificial intelligence. Um, and I think that clearly there are some positive features that could really contribute to the better communication and having a better relationship between the provider and the patient. Being able to get the provider not to have to be focused on the computer screen the whole time. A number of the tasks that require the doctor to be looking at the computer screen can be automated by AI, and I think AI can also serve as a coach for the provider to improve communication, and particularly empathic communication. The downside is, I think that there could be another ring around this vicious circle of AI if it's just trained on data sets that incorporate or that conclude all of the old racial and racial biases that we know about. So I think it has potential. I think it's very telling that the people who developed AI are going to Congress begging them to regulate it, because I think it's been released into the wild probably prematurely.
And it sounds like you're suggesting that there's a human element of interpretation that's needed for it to be beneficial in the long run. So taking that information and using it for good, as the doctor in this case might
Yeah,
need it.
I really agree with that. There's an interesting article that although AI has been able to pass the bar exam in several states, it could not pass the board certification exam in orthopedics. So I'm hopeful that there's still a role for people like me.
Job security. We have a question here that I'll read from the chat. How do you see values-based bundles impacting patient value on care for osteoarthritis in particular?
Well, I think that the bundles have to include a patient experience measure that's meaningful. Um, and I think that this really does it's an opportunity for coaching of providers, but it does require a great deal of infrastructure. I think the joint replacement service at the University of Pittsburgh is a really great example of this, because it has really been re-engineered to deal with the bundles, but also to make sure that the patient experience is as positive as possible. So I think there are people that are doing this. It needs to be more generalized.
And just to kind of piggyback on that question, you mentioned a surgical bundle, a joint replacement bundle, but what about some non-surgical types of care that might be included kind of before the patient gets to the point where they need a joint replacement?
Yeah, I think that's really important. The one thing, again, back to the University of Pittsburgh, they have really they've led the way as far as preoperative optimization, and so they do have a large patient base with multiple comorbidities. Obesity and comorbidities, but they also have a program to manage those and to optimize the uh, you know, patient's physical condition before surgery. And so the American College of Surgeons also has what's called the Safe for Surgery program, which is a preoperative optimization program I think those are very important because in a lot of situations, people were just being told, no, you're too fat and your diabetes is out of control. You can't have a joint replacement. Whereas at UP, they will say, you can't have a joint replacement. We want to make sure that you have the best chance to benefit from it.
Great, thank you. So here's a question, and I don't see any other questions, so I'll read this one. If other people have questions, feel free to type them in the chat. Dr. Burney, this is a tough one. Um, how can a fee-for-service system be transitioned to a value-based system?
Well, it's interesting because the fee-for-service system is very resistant to change. I think it goes all the way back to when Medicare was first, Medicare was first passed in the 60s. The condition for Medicare passing was that it be fee-for-service, and so it has deep roots that are hard to pull up. I think that there are a lot of the systems now are going to sort of blended services where there's partial capitation and partial fee for service or partial service bundles. And the capitation fee is to manage is to cover the cost of data management and the ancillary services that are included in the bundle, uh, that are required by the bundle. So I think some mix is going to be necessary, but I do think that the mix will gravitate more toward the right on that chart that I showed you with the blue arrow. It will be more toward providers accepting more financial risk and more accountability.
And what would motivate a system to transition to value-based care?
Well, I think what will motivate the system is the fact that it is federal policy, and the federally funded programs, Medicare and Medicaid, are a huge proportion of all funding. They basically provide insurance for about 40% of the people in the country. And in my state, in New Mexico, Medicaid is 50% of the population. So just the fact that they have that level of market share, if you want to call it that, gives them the power to go ahead and push these things through.
Okay, great. Thank you so much, Dr. Burney. Questions, feel free to type them in the chat. Otherwise, I am going to go ahead and launch a poll, and I will leave that up for the remaining duration of the webinar. If you can take it, we would appreciate it. And while I'm doing that, I'll go ahead and read one more question that did come in. So this question is related to artificial intelligence. And the question is, AI technology has very little data incorporating disparate communities. What can we do to encourage more information to be collected so that disparities don't increase?
I think that, thank you, Verona, for that question. I appreciate it. I think that's a little bit above my area of expertise. I do think that the data sets that AI are trained upon are really opportunities, but also threats, because some data sets will incorporate biases and tend to worsen these things. So I think it's going to require somebody smarter than me to answer that question. And I don't want to I don't want to cop out on this, but I do think that this is one of the really huge questions as far as incorporating AI into healthcare.
So lots of regulations and things that still need to be worked out on that front.
Well,
Well,
I would think so. I would hope so.
that's great. Well, thank you, Dr. Burney. Really appreciate your talk today, and thank you to everyone who attended today's presentation. I hope you can join us next month on July 19th for our Lunch and Learn featuring Robin Gilbert, who will present Fair Health Shared Decision-Making Tools for Hip Osteoarthritis, combining cost and clinical information. And I will drop that registration link in the chat, and then will also be in the follow-up email that goes out. So thanks to everyone for joining today, and hope you have a great rest of your day.